So hemostasis. This is how do you stop bleeding, basically. You get cut, as you can see here. This is the blood vessel, this is the lining of the blood vessel. Let's say you get cut, you get some blood dripping out, as you can see. What is gonna happen so that we don't have blood dripping out of us constantly for a very, very long time? What is gonna happen? Well, first of all, you're gonna get a primary hemostasis with a platelet plug formation. So that's the first stage of hemostasis, a platelet plug formation. And then the second stage is going to be fibrin cross-linking of the platelet plug. Because we need this second stage because this first stage is not very stable. You get a weak platelet plug. This platelet plug can dislodge, just for various reasons, and then you can get more bleeding. So you need to stabilize it with a fibrin cross-linking of the platelet plug. This is what I've drawn here in the orange. That's the fibrin cross-linking. It's formation of a thrombus. This is much more stable. So let's get into each of these details. We're going to start with primary hemostasis and how exactly we get that platelet plug formation. So first step, again, we see endothelial injury. So we see here, this is the injury. This is the blood vessel. This is the endothelial cells. What you're going to get is you're going to get a vasoconstriction. What happens is this is a reflex neurovasoconstriction, and it's going to get narrowing of the lumen. The other way you get vasoconstriction is these damaged cells are going to release endothelin. They're going to release these endothelin. Endothelin just causes vasoconstriction. You get vasoconstriction, you get less blood flow through this area, through this damaged area, and then the constriction also helps with hemostasis. It helps blood clots form better. That's why the number one thing you want to do when you get bleeding, especially if you're in surgery or you have some trauma, is you want to compress that blood vessel. It's going to decrease the blood that's coming out, and you're also going to be encouraging hemostasis. So, step one, vasoconstriction. Next thing that's going to happen is you're going to get von Willebrand factor. It's going to come down and bind to exposed subendothelial collagen. So we have subendothelial collagen that's now exposed because of this cell that's now damaged. So von Willebrand factor can now bind to this subendothelial collagen. And von Willebrand factor is derived from platelets as well as Weibel Palade bodies of the endothelial cells. So there's a Weibel, this is how you spell it, Weibel Palade bodies, I don't know. Von Willebrand factor, Weibel Palade bodies of endothelial cells as well as from platelets. So that's the next step. After that, what's going to happen is that now this von Willebrand factor binding is going to allow platelets to bind. Okay, platelets need to bind to the von Willebrand factor with its GP1B receptor in the green that I've now covered. So platelets binding to von Willebrand factor using the GP1B receptor. So that's why we need this von Willebrand factor. This platelet can't bind to the subendothelial collagen itself. It needs to bind to this von Willebrand factor. What's going to happen with this binding is you're going to get shape change of the platelet, as you can see here, the shape change, and it's also going to get release of platelet contents. So you can see the contents here are calcium, thromboxane, A2, and ADP. So what is the functions of each of these? Thromboxane helps promote platelet aggregation. Okay, so aggregation, that's just platelets coming together. Calcium is necessary for the coagulation cascade, so that's the secondary hemostasis. We're going to talk about that in a second. And then ADP is what it's going to do is going to bind to platelets. It can bind to itself or to other platelets, so it can go to other platelets. And it's going to induce expression of the GP2B3A receptor. So this is the GP2B3A receptor. Inside is the red one, inside the platelet. It's going to induce expression. So with this ADP binding, it's going to bind here. Now it's going to cause this receptor over here to go and to be expressed on the platelet. And why do we need that? That's because this GP2B3A receptor is needed. Fibrinogen will bind to it, and it acts as the linking molecule to induce platelet aggregation. So now you can see that other platelets can now bind through this fibrinogen. The GP2B3As will bind, and that's how you get platelet aggregation. You get more and more platelets, and you see you now formed a little weak platelet plug. Okay. So just to reiterate, what do we say? We said vasoconstriction first, von Willebrand factor comes, binds to subendothelial collagen, and now the platelets can bind to the von Willebrand factor with the GP1B receptor. And then next you're going to get the ADP binding, or ADP release. You get shape change, you get a couple more release, calcium release we said calcium was useful for the secondary hemostasis. Thromboxane A2 we said was useful for platelet aggregation. ADP acts on platelets, induces GP2B3A expression, and then you get platelet aggregation. So that's primary hemostasis. Now we have a weak platelet plug. We need to stabilize it. We need to make it more strong. So that's what we're going to do with the secondary hemostasis. So secondary hemostasis is mediated by clotting factors that we have in our blood, and they're going to be activated. They're normally just chilling. They're just floating around the blood. They're non-activated. What's going to happen is you have we just call them different numbers. So we have clotting factor 7, and what's going to happen is you're going to have these damaged cells in the blood vessel. It's going to be damaged. They're going to release something called tissue factor. Tissue factor is going to stimulate this factor 7. They're going to help factor 7. They're going to stimulate something called factor 10. Okay. Factor 7 is going to stimulate factor 10 and make it activated. Okay, so 10 is going to become activated. So this is called the extrinsic pathway. This is extrinsic because you need something extrinsic, which is tissue factor, to activate this pathway. Now, the other thing that can happen is you can have the intrinsic pathway. And what happens is you have factor 12 now. Factor 12 is another one. It's just hanging around, and then when it sees subendothelial collagen, why did we say we had subendothelial collagen? When we say we get damage to these cells, and then so the collagen under it's going to get exposed, and so then factor 12 is going to get exposed to subendothelial collagen. It's going to get activated, and then so now you get 12A. It's going to go activate factor 11, and then that's going to go activate factor 9, and then factor 9, with the help of factor 8A, is going to also activate factor 10. So you see that this intrinsic and the extrinsic pathways they converge towards activation of factor 10, and that's why this is going to be called the common pathway, what we're going to talk about next, because it's common. It's due to the convergence of both the intrinsic and the extrinsic pathways. Factor 10 we say is activated now. It's going to go and activate factor 2. So let's just erase some things, clear things up a little bit. Factor 2. So we have factor 10A activates factor 2. Factor 2 we call either prothrombin before it's activated, and thrombin. And what thrombin is going to do, thrombin factor 2A, when it's activated, it's going to activate factor 1. Factor 1 gets activated, and factor 1 is called fibrin. So fibrinogen becomes fibrin. And activated fibrin is going to now cross-link, and you're going to get a cross-linked fibrin clot. So this fibrin is in the platelet plug. We had all these platelets here. Now we're going to get cross-linking of fibrin through the activation of this coagulation cascade. So I just want to review everything that we talked about here. We have the intrinsic and the extrinsic pathways. Extrinsic arises due to damage to the cells, release of tissue factor, activation of factor 7. Factor 7 is going to go and activate factor 10. The other way we get activation of factor 10 is through the intrinsic pathway, which we said was through the subendothelial collagen. 12 gets into contact with subendothelial collagen, becomes activated into factor 12A. 12A goes activate factor 11. Factor 11 goes activate factor 9, so now it's 9A. And then 9A plus 8A, so factor 8 also helps out, also activates factor 10. Okay, now factor 10 is going to go activate prothrombin. It's going to do that with the help of factor 5. So prothrombin gets activated, now you get thrombin. Thrombin is now going to go activate fibrinogen into fibrin, and now you can get cross-linking of the fibrin clot. So that is it for our coagulation cascade. I want to add one more thing. We have lab tests that we use to measure this, how well our coagulation cascade is working. We have the PT, this is the prothrombin time, and then the PTT, the partial thromboplastin time. These measure how well the coagulation cascade is working. So both of these look at factors in the common pathway. So this is the common pathway here. They look at all these factors in the common pathway. PT is also going to look at factors in the intrinsic pathway. So PT looks at the extrinsic pathway, and the PTT is going to look at the intrinsic pathway. And the way I remember that So these are they both work on the common pathway, so it doesn't really help us. But if this is elevated and this is normal, then we know that something's wrong with the intrinsic pathway. Something has to be wrong here. Can't be wrong in the common pathway, because if something is wrong in the common pathway, PT would be elevated as well. But if only PT is elevated, you know something's wrong in the intrinsic pathway. If the opposite was true, then you would know something's wrong in the extrinsic pathway. We remember PT goes with the intrinsic pathway because PTT is the longer name. You have more factors in the intrinsic pathway here, okay? And then PT then goes with the extrinsic pathway, which is shorter. So that's how we remember the two of those. So that's it for our first review. Actually, let's go into activation and clotting factors before we stop. So we have all these clotting factors I told you about, factors 2, 7, 9, 10. And these are not all of them, but some of them. These get activated by reduced vitamin K. In the liver, you need reduced vitamin K along with gamma-glutamyl carboxylase. You need to add a carboxyl group to these factors, and these carboxyl groups will make them activated. You add a carboxyl group, you activate them. The other thing that I want to take note of is protein C and protein S. So these proteins are actually anticoagulatory. Okay, these stop coagulation. So what happens is, this is a kind of a tangent, but it's also important, is you can give warfarin. Let's skip all this. Warfarin, what it does is you need to use reduced vitamin K for this activation. To get reduced vitamin K, you need epoxide reductase, which basically reduces oxidized vitamin K. Warfarin blocks this. If you block this, you get less reduced vitamin K. You don't get this activation. That's how you get anticoagulation. Now you have inactive clotting factors. Inactive clotting factors mean that you can't clot, so you get anticoagulation. But what happens is warfarin is this protein C and protein S. You give them warfarin, you stop the activation. Whatever stuff that was activated, so you still have some of this, but they're gonna go away. They have half-lives. Protein C and protein S have shorter half-lives. They're gonna die off fast. These are procoagulants. Procoag. These are anticoag. So now you have less anticoag and more procoag that are still for temporarily. Okay, this is the stuff that's still there after we blocked everything. So now we're actually in a procoagulatory state here. So for a brief period, you have an imbalance with too many coagulatory factors and not enough anticoagulatory factors, and you get a transient hypercoagulable state. So that means that you're going to be at risk for clots. And what can happen is you can get tissue and skin necrosis because you can get clotting and thrombosis of small vessels. So you get thrombosis of small vessels, you get thrombosis, you get decreased blood flow, you're going to get necrosis of tissue and skin, and that happens in transient fashion after warfarin initiation. It can happen, doesn't always happen, something you want to watch out for. So let's erase everything and talk about vitamin K deficiency. Sorry, I was a little out of order here. But so vitamin K, as we see, is important for this activation of clotting factor. We just said it's a cofactor for carboxylation, which activates them. So if you have deficiency, then you get inactive clotting factors. And what do you get? You get problems with secondary hemostasis. So how do we get vitamin K? Normally, vitamin K is taken in through the diet, or it's produced by bacteria in the GI tract. So if you get deficiency, then if you have a problem in either of these routes to get vitamin K. So newborns have problems because they have not yet been colonized by vitamin K producing bacteria in the GI tract. So that's why for newborns we need to give them vitamin K shots. We need to give them vitamin K shots at birth to prevent deficiency of vitamin K and bleeding. And what you're going to hear in the story a lot of times, you're going to have a baby that's bleeding, and you're going to hear that their mother just refused to give them a vitamin K shot, or their mother gave birth at home, so they're not at the hospital where they would normally get a vitamin K shot, and they're bleeding. So that's the answer to why the kid's bleeding, because it's vitamin K deficiency in lack of active clotting factors, so it's bleeding. Next, if you have long-term antibiotic therapy, what does that have to do with vitamin K deficiency? We just said you get you get loss of vitamin K bacteria, producing bacteria in the GI tract from long-term antibiotic therapy. Finally, the last thing that can happen is malabsorption, which we talked about in the GI system. So what is malabsorption? What were the fat soluble vitamins that I talked about? Fat soluble vitamins were vitamins A, D, remember A, D, E, K. So vitamin K is also deficient here. You get vitamin K deficiency, you get bleeding. So that is it for our first review of primary hemostasis, secondary hemostasis, and then activation of clotting factors.